Hi, I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair at Baylor University Medical Center and Director of Breast Cancer Research at Texas Oncology and US Oncology in Dallas, Texas. Question is, which patients should we be thinking about and discussing preoperative pembrolizumab with in our practice? And so we turn to the KEYNOTE-522 data that were updated by Dr. Peter Schmid at an ESMO plenary session in July 2021. And KEYNOTE-522 enrolled triple-negative breast cancer patients with stage 2 or stage 3 disease. And so the patients either had to be clinically node positive or they needed to have T2 or greater cancers if they were clinically node negative. And they could not have a history of a clinically significant autoimmune disease. And all patients received the standard chemotherapy backbone of paclitaxel carboplatin. Carboplatin could be every 3 weeks or weekly, all followed by AC. It was given every 3 weeks, and patients were randomized to placebo every 3 weeks during the preoperative chemotherapy or to pembrolizumab every 3 weeks. And then all patients went to surgery. And then after surgery, patients continued with 6 additional months of pembrolizumab every 3 weeks or placebo every 3 weeks. And capecitabine was not given to those patients who did not have a pathologic complete response because the study was started before the worldwide understanding and acceptance of the CREATE-X trial that showed improvement in disease-free and overall survival with the addition of adjuvant capecitabine in patients who didn't get a path CR. And so patients there was a co-primary endpoint of the trial, which was pathologic complete response rate, which on the protocol specified evaluation of path CR with the chemotherapy alone, it was 51%. And with the addition of the pembrolizumab, the path CR rate was 64.8%. So from 51 to 65% approximately was the delta in the path CR. But most importantly, at this interim analysis 4 that Peter Schmid presented at ESMO in July, there was a 7.7% statistically significant and clinically meaningful improvement in event-free survival in favor of the pembrolizumab. The 3-year median event-free survival was 76.8% with the chemotherapy placebo and 84.5% with the chemotherapy plus pembrolizumab. And most of the reduction in terms of the events was in the prevention of distant recurrences. So it was 12.8% distant events with the pembrolizumab versus 20.3% with the placebo. And the patients benefited with regard to event-free survival, regardless of their clinical nodal status at presentation. Both patients benefited equally well, whether they were node negative or node positive at initial presentation. Furthermore, regardless of PD-L1 status, patients' event-free survival was substantially improved with the addition of pembrolizumab, regardless if the cancer was PD-L1 negative or positive, so we don't have to check for PD-L1. And then lastly, there was an exploratory endpoint done looking at event-free survival in patients who did have a pathologic complete response versus those who did not have a pathologic complete response. And even in the patients who did not have a path CR, there was a more than 10% improvement in event-free survival with the pembrolizumab, 67.4% 3-year event-free survival in those who did not have a path CR with the pembrolizumab versus 56.8% 3-year event-free survival in those who got placebo. With regard to those who did get a pathologic complete response, it was about a 2% improvement in event-free survival in favor of the pembrolizumab. Of course, we need longer follow-up. There were some immune-mediated AEs. Most of them were low-grade and manageable. However, there was a 1 or 2% pneumonitis, colitis, hepatitis, and then a very small risk of a long-term serious immune-related adverse events such as hypophysitis, adrenal insufficiency, insulin-dependent diabetes. These glandular immune-related adverse events can be very serious and can be lifelong. So there's a small risk of this, but certainly something we need to discuss with our patients. So we want to offer the preoperative pembrolizumab now as a new standard of care in combination with paclitaxel carboplatin, followed by AC, and give the pembrolizumab in the preoperative setting and give the pembrolizumab in the adjuvant setting in stage 2 and 3 breast cancer patients with TNBC who do not have a clinically significant autoimmune disorder. And the patients will have at the 3-year mark an absolute improvement in event-free survival of 7.7%. And the curves continue to pull apart, so we await further follow-up.